All right, so I missed lecture this morning because of traffic. Um, so let's go through what I had planned on doing today. So we're going to start the pulmonary system, so the respiratory system. When we deal with the respiratory system, we're dealing with basically two things. Number one, we have to get air into and out of the lungs. And number two, we have to get oxygen from that air into the blood and get rid of CO2 and expire that or exhale that. So we've got pulmonary mechanics, ventilation, to deal with, and then we've got gas exchange and transport to deal with. So we're going to do that in two separate topics. And so I put this up front because this is what it's going to lead into when you do the pulmonary unit, which is, I think, P2 or P3, I can't remember, where you'll go through the differential diagnosis for people who have pulmonary problems, and you'll have to understand basically how the system works to begin with in order to understand what's wrong with them. So you've got, most people come in with one of two complaints. They're either coughing and wheezing, or they're short of breath. They have what's called dyspnea. Apnea means you're not breathing, right? A, in medical terminology, means absence of or without. So somebody who has apnea is not breathing, right? So you sleep apnea, you stop breathing for a short period of time during sleep. Dyspnea, the term dys, I always think of it as dysfunction. Dys means something's wrong, it's not normal. Right, so people with dyspnea usually complain of being shortness of breath or having difficulty breathing. So the first thing you usually do is you do what's called spirometry, and I'm going to describe spirometry for you a little bit later. Basically, you have somebody breathe into and out of a tube with their nose. You put a mask over their nose and their mouth, one of those cup masks, or you have them breathe into and out of a tube with their nose plugged, which is what we do in lab in the undergraduate course. And then you measure the volume of air moving into and out of the lungs. Now, if spirometry is normal, then depending upon what their complaint is, there could or could not be a problem. So we're going to deal with the coughing and wheezing complaint. Somebody comes in coughing, I just did that. Wheezing, so difficulty breathing. When they breathe, it kind of whistles through their tubes. If they get a normal spirometry result, you might consider doing what's called a bronchial challenge test. Again, you're going to talk about that some other time. I'm not going to go into that. You could treat for GERD, gastroesophageal reflux, reflux of stomach contents. When I talk about the GI tract, we'll go through that. Can cause difficulty breathing when those acidic GI contents get into the lungs or the trachea. They can cause damage to the tissue. Or postnasal drip, which may be associated with a lot of things. There may be rhinitis, which is inflammation of the rhinus, which is the nose. Maybe cough, cold, allergies, viral infection, lots of different things. If they have indications of an obstructive disorder, again, when we go through spirometry, I'll show you what that looks like. Then you can do a bronchodilator testing, so you'll give them a bronchodilator like albuterol, which is an agonist for beta-2 receptors, beta-2 receptors in the coronary arteries and the skeletal muscle arteries and the bronchioles of the lungs cause dilation. So stimulating those beta receptors cause dilation. So is that going to relieve the symptoms or not? Right, obstructive disorders mean just what they say. They're obstructive. There's an obstruction. There's something blocking flow of air into and out of the lungs. That blockage could be mucus. That blockage could be you swallowed, or excuse me, you inhaled something rather than swallowing it. So if you were eating something and talking at the same time, you may have inhaled a piece of food or whatever. There are cases where people who have blown up balloons have inhaled the balloon. So there's a bunch of different things that can cause an obstruction. Restrictive disorders, on the other hand, are restrictive to airflow. So there's something going on that's restricting airflow. It could be that the lungs themselves no longer collapse or return to their normal shape and volume, so you've lost elasticity. Or could be that you have a problem with your lung tissue itself. Something's going on with the lung tissue. So you would check the lung volumes. Normal lung volumes, you would then go to what is called, you would check the diffusion capacity. It's a DLCO test, diffusion capacity of oxygen. So you would give someone oxygen and see what their diffusion capacity was by measuring their arterial oxygen. If it's normal, you may suspect that then that person has asthma. So what their lungs are working normally, it's just the bronchial tubes are constricted. If it's decreased, you may suspect some form of COPD. A low DLCO, a low diffusion capacity for oxygen. You then would check for other diseases like interstitial lung disease, neuromuscular changes, chest wall changes, etc. Now, dyspnea, on the dyspnea side, so people having difficulty breathing, people feeling short of breath, that could be a few things, a lot of different things actually. If spirometry indicates a restrictive disorder, then you would go through all these possibilities. If it indicates an obstructive disorder, then you would do the same thing you did over here, right? You would do bronchodilator testing to see if their bronchioles dilate normally when stimulated with a beta-2 agonist. If they are normal and they still have dyspnea, then you're looking at possible cardiovascular problems. Right, so you would do pulse oximetry to check their oxygen level in the blood at rest and with exercise. You would do other tests like maybe checking their hemoglobin level, maybe checking their vitamin B12 levels, other vitamin levels, iron, obviously. Anything that deals with transport of oxygen in the blood. Because if they're short of breath and they have normal breathing, that means the problem is somewhere in the cardiovascular system. So the purpose of the respiratory system is to provide oxygen to the cells and to the cardiovascular system, which will transport that oxygen to cells, or remove CO2. Now, by far, the most important thing that the respiratory system does is get rid of CO2. CO2 is a volatile acid. It is a byproduct of cellular metabolism. breaking down glucose, C6H12O6. In order to extract energy from those covalent bonds to make ATP, is going to provide CO2, water, and heat as waste products. Now, all of your cells are doing this. All of your cells are making CO2 at a very high rate. And if you increase metabolism, right, if you increase due to exercise, due to thyroid hormone, growth hormone, whatever, increases in metabolism are going to cause increases in CO2, and you've got to get rid of it because it's a waste product that is acidic, and it will cause you to go into acidosis, and acidosis causes proteins to unfold and not function properly. So you need to get rid of the CO2. As far as oxygen is concerned, you can live in low oxygen environments, but you can't live in an environment where you can't get rid of CO2. And that's the basic gist of it. And we'll go through that as I go through explaining how it's transported and used. So what we do is, first of all, ventilation. We bring air into our lungs and then expel that air from our lungs. That is the process of ventilation, moving air through pipes or tubes. Diffusion, so gases moving across the respiratory membrane into or out of the bloodstream. Oxygen and CO2 transport within the bloodstream, and then, of course, regulation of ventilation. If you need to get rid of CO2, if you're exercising and producing more CO2, you have to breathe more rapidly, you have to ventilate more to get rid of that CO2. If your demands are lower, then you need to breathe less. So you have to figure out a way to regulate ventilation and match that to the needs of the body. Now, throughout the respiratory system, we're going to be talking about laws of physics because we're dealing with flow of air through tubes. We're dealing with properties like elasticity, the ability of something to return to its normal shape or to maintain its shape. Compliance, the ability of something to stretch or the willingness of something to stretch or change its shape. Gas laws, we're dealing with oxygen and CO2, so we're going to have to be dealing with gas laws. Air around you is a mixture of nitrogen, oxygen, CO2. So air is about 70%, 78% nitrogen. It's about 21% oxygen, right? So if you do the math here, you're at 99% already. So less than 1% of the air that you breathe is made up of CO2, carbon monoxide, other gases like xenon, the noble gases, etc. So right there, oxygen levels. So we're going to be dealing with gases in the vapor state, and then how gases dissolve in fluids because they have to be transported in the body by the cardiovascular system, which is filled with fluid, blood, and blood plasma. So we start off with gas laws. Gas laws are all derivations of the ideal gas law, which is PV equals nRT. Right, and it's just rearranged here. P equals nRT over V. And the pressure of a gas is proportional to those things on the top and inversely proportional to volume. Now, we talked about regulating body temperature. We said body temperature is normally kept within a narrow range. So temperature is pretty much constant, so we can eliminate that from the equation for the most part. N is the number of moles of gas. That's not going to change significantly. R is a constant. That's not going to change, obviously, because it's constant. So essentially what we're dealing with is the pressure, P, is going to be equal to some constant, depending upon the gas, over the volume. And this gives us our first law for respiratory physiology, and that is Boyle's law, which Boyle's law encompasses ventilation. It basically describes how it is that you can get air into and out of your lungs. Boyle's law, the pressure and the volume in one state is going to be equivalent to the pressure and volume in a different state. So, when you expand the lungs and you increase the volume, in order to maintain this relationship under Boyle's law, then you say, well, the container has gotten larger, so the volume has increased. Therefore, the pressure of the gas in the container goes down in order to make this relationship work. By the same token, when the lungs return, so during exhalation, when the lungs return to normal shape and size, in that case, the volume is going down, and so the opposite, and that's going to increase the pressure of the gas that's in the container, in the lungs. And that's going to allow you to expel air because the pressure in the lungs is going to be greater than the pressure in the atmosphere. Other gas laws that we're going to deal with, I'm going to talk about the concepts, but I want you to know which law is involved with each concept. Obviously, Boyle's law deals with ventilation, movement of air into and out of the lungs. Charles' law. Charles' law is an interesting law because in that law, pressure is your constant. So temperature is going to change, but pressure is the same. So gas volume varies in proportion to temperature. And that's going to come into play because the air that you breathe is not the same temperature as your body. So air is going to be warmed and humidified as it goes from the external environment down into the lungs. And of course we all know that if you heat air, if you heat any gas, it expands. So air is, what you breathe in is going to expand somewhat during the process of inhalation. Dalton's law is my favorite. And it's my favorite because my name is Dayton. And throughout my entire life, people have been calling me Dalton. So this is my favorite law. And Dalton's law is the simplest as well. Basically says that in a mixture of gases, that mixture in our case is going to be called air, the total pressure, so usually at sea level, the pressure of air is 760 millimeters of mercury. And Dalton's law says that the total pressure of any mixture of gases is equal to the sum of the pressure of each individual gas in the mixture. And each individual gas contributes in direct proportion to its concentration. So we said that oxygen is about 21% of the gas mixture that we call air. So it should contribute to 21% of the pressure to the overall gas. So you can relate concentration and pressure. They're equivalent. And that's going to be very important when we talk about gases, because we're going to talk about partial pressures. We're going to talk about the pressure of a gas in a total mixture, the partial pressure. So 21% of 760, I'm not going to do the math. It should be about 161 or somewhere thereabouts. So the concentration in the mixture is 21%, and the partial pressure is 21% of 760, which is 161. Henry's law deals with solubility. Basically, the volume of dissolved gas is proportional to partial pressure, which means that since we're dealing with water, the amount of gas that dissolves in liquid in water is going to be determined by the partial pressure. So if you raise the partial pressure, you're going to get more gas dissolved in the liquid. If you lower the partial pressure, you'll get less gas dissolved. Now, how this relates, we'll get into that when we talk about exchange between the lungs and the blood. One of the things you should recognize is that drinks that you are probably drinking now that are carbonated have a lot of CO2. And the CO2 was added by having CO2 bubbling through the liquid, right, so that the partial pressure of CO2 was higher, and that caused more CO2 to enter into the liquid phase in that mixture. Then, of course, as soon as you opened the bottle, you crack the top, you get this psst sound where CO2 that has left and entered the gaseous phase is now released. And then as soon as you do that, now the partial pressure of the gas in contact with the liquid is lower than the liquid, so the CO2 is going to start leaving the liquid. So if you leave a soda out for a long period of time exposed to air, it's going to be flat. It's going to lose its CO2 content and not have any bubbles. And that's Henry's law. I know you were all dying to know exactly why that happened. And that is Henry's law. Brief glide through the anatomy, because you should already know this. If you don't, go back and review it. So you've got two lungs, one left, one right. There's a single trachea that feeds these lungs. It breaks off into a primary bronchus, left and right, which then break off into secondary bronchi, which are going to be the lobes of the lungs, and then tertiary bronchi, and then into bronchioles. And if you look at the histology of it, these pseudostratified ciliated columnar epithelial cells are going to be found in the trachea and the bronchi, and then down into the bronchioles where they will terminate, and you will start to have more of a cuboidal or columnar to cuboidal cell, right? And the cilia are important because they sweep debris that you breathe in out of the lungs so that you don't get accumulations of stuff in your lungs, which can cause coughing and wheezing or obstructions. Now, these conducting areas, the areas that are responsible for conducting air into the lungs, are surrounded by C-shaped cartilaginous rings made up of hyaline cartilage, which prevent collapse of the airways. Now, the highest resistance to flow, again, we're going to be going back to Poiseuille's law, Q equals delta P over R, which governs flow of anything, liquid or gas, through a tube. Right, so the flow is going to be equal to the pressure gradient over the resistance. And the resistance, as we've talked about before, is determined by a bunch of different factors, all of which are irrelevant except for radius. So 1 over r to the 4th, so we can say, for our purposes, Q equals pressure gradient times radius to the 4th power. The conducting zone, because it has C-shaped cartilaginous rings, does not dilate or constrict. So the resistance is fixed. The only way that resistance is going to change is when you have an obstruction, such as an accumulation of mucus, you swallow a Lego, whatever, some type of obstruction, right? You're not going to get any type of appreciable constriction or dilation until you get down into the bronchiole area. When you lose those C-shaped cartilaginous rings, you've got now smooth muscle that can control the diameter of those bronchioles. And then once you get down further into the smaller terminal bronchioles, right, respiratory bronchioles, alveolar ducts, and alveoli make up your respiratory zone. And it is at those points where the distance between the capillary and the air that is filling those tubes or the alveolus is short enough, the distance is short enough where diffusion can take place. So that's why it's called the respiratory zone. That's where actual exchange of gases can occur. Ventilatory muscles, over here we see the lungs at rest, and that's what this represents here. The diaphragm, a dome-shaped skeletal muscle controlled by the phrenic nerve. Remember a phrenic nerve? Talking about C2 to C5, cervical level C2 to C5. Motor neurons controlling the diaphragm. So when this dome-shaped muscle contracts, it's attached here and here. When it contracts, it's going to get shorter. When it gets shorter, it's going to move down into the abdominal cavity. It's going to press on the abdominal contents, right? Muscles, when they contract, they get shorter. As this dome-shaped muscle gets shorter, it becomes less of a dome and more of kind of a straight line. These lungs are attached because there is liquid, thin film of liquid here, which is going to adhere the lungs to the diaphragm, so that when the diaphragm contracts and moves, it's going to pull the lungs. This is a property we refer to as called fluid cohesion or cohesiveness. If you want to know what that's all about, then just take a really cold drink, pour it into a glass, a real glass, not a cup or anything plastic, a glass, set it on a coaster or something else, and then let it sit for 15-20 minutes. Pick it up. The coaster will be attached or adhered to the bottom of the glass. That's fluid cohesion. That's where water molecules are attracted to each other and try to get away from air, so they become more dense at the interface between air and liquid. And they adhere things to each other. So the lungs are basically adhered to the inner chest wall and to the diaphragm, and this is an enclosed system. So if the volume of this chest wall increases, the volume of the lungs increases. If the volume of the chest wall decreases, the lungs decrease. The lung volume decreases. So the expansion of the lungs causes the pressure in the lungs to decrease, right? Because the volume has increased. So here we had P1, V1, and here we have P2, V2, Boyle's law. So what that's going to mean is, because the pressure on the outside is higher, air is going to be forced into the lungs from high to low, as all things in physiology move. The muscles that do this, primarily the diaphragm contraction pulls on the lungs, increases the volume, decreases the pressure. If you want to, you can add a little more to it, primarily during respiration. The diaphragm and the external intercostal muscles are the muscles that are involved. The external intercostals, if you're familiar with eating ribs, you'll notice that if you take the rib and you look at the muscle on one side of the rib, the fibers are oriented in a 90-degree angle to the muscle on the other side of the rib. And that's because the internal and external intercostals have fibers that move perpendicular to each other because they have different actions. The external intercostals are responsible for flaring. So they'll take a normal rib that may look like this. Make sure I have the pointed ridge. They will pull that pointed ridge so that it flares out, right? That will increase the volume of the chest cavity in the horizontal plane. Right, the diaphragm is moving in the vertical plane, so this is a horizontal increase in volume. Sternocleidomastoids, if you want to breathe even more, you contract your sternocleidomastoids, which attach to the mastoid process on the skull, if you remember that from anatomy. And it has it has three different heads to the muscle. It has a head that attaches to the sternum, and then it has a couple of heads that attach to the clavicle. Sternocleidomastoid. That pulls the rib cage up towards the head, increasing the volume in the vertical direction. Assisted by the scalenes. So normal inspiration is diaphragm and external intercostals. If you want to increase the volume available, deep breath, then you do the sternocleidomastoids and scalenes. Expiration. Normal expiration is the diaphragm. Diaphragm relaxes, returns to normal shape and size. You can get a little more forceful by using the internal intercostals, which now are going to do the opposite. They're going to take the rib and flare it in. So that the volume in the horizontal plane decreases. And then if you really want to blow up a balloon or do some really forceful expiratory maneuver, you can use the abdominal muscles. And the abdominal muscles contract. It pushes the abdominal contents up against the diaphragm. So if you decrease the volume of the abdominal cavity, you're going to push the gut contents up into the thorax and decrease the volume of the thorax. And again, you're in a P1V1, P2V2 relationship, Boyle's law. Decreasing the volume in the thorax increases the pressure, and you're going to be able to forcibly exhale. So that's all ventilation is moving air through pipes. So under normal conditions, you've got inspiration. All right, so you've got these lungs. You've got a pleural cavity, which has some liquid in it to cement the lung wall to the inside of the chest cavity and to the diaphragm. All right, so this intrapleural pressure, this pressure that's in the tissue in between the lungs and the chest wall, is about 756 millimeters of mercury. It's lower. Remember we talked about with the lymphatic system, because lymphatic drainage is usually greater than capillary leakage, that there's a negative pressure in the tissue, in the organ. This is the same thing here. There's always a net negative of about -3 millimeters of mercury. And that helps to keep the lungs inflated. A pneumothorax which means air in the thoracic cavity, pneumothorax. You have a hole in the chest wall. Either you got hit by shrapnel, you got stabbed, there was a puncture wound, whatever, your sister or brother poked a pencil in your chest, something. Somehow this pleural cavity came to equalize in pressure to the external atmosphere. When cases like that occur, you get a collapsed lung. Atelectasis. Lung collapse. And the way that is fixed is by plugging the hole and then creating a vacuum, so sucking excess pressure, excess air out of the chest cavity, the pleural cavity, so that the lung can inflate. Under normal conditions, however, inspiration, the diaphragm contracts as we go from here to here, right? Pulls on the lungs because of that fluid cohesiveness. The pressure inside the lungs now becomes less than atmospheric pressure. So air moves into the lungs when the diaphragm relaxes. Then it moves up. Boyle's law, as the volume decreases, the pressure increases. So now you've got a pressure in the lungs, an intrapulmonary pressure, which is higher than outside, so air leaves. All of this, of course, depends upon having normal, functional lung tissue. And lung tissue, one of the things that we deal with, well, a couple of things that we deal with, are compliance and elasticity. Elasticity is a property whereby something either does not change shape, refuses to change shape, like a steel I-beam, has maximum elasticity, or once you change its shape, once you let go of it or remove the deforming force, it returns to normal. In the case of a rubber band or a balloon or something like that. Compliance is the willingness to change shape. So a balloon is compliant and elastic. That changes shape and it returns to its somewhat original shape after it's been blown up. It loses some elasticity every time it's blown up. Steel I-beams, however, are not incredibly compliant. You have to heat them in order to get them to change shape. Under normal conditions, forget it. You just can't bend a steel I-beam, so it's not compliant. Now, as far as the lungs are concerned, you've got the connective tissue, which has fibers in it. And that connective tissue is going to have some determination over the compliance. But you're also going to have the liquid that lines the lungs in order to increase gas exchange. That's going to create a surface tension, which may cause alveolar collapse. If you've ever washed your car and you look, there's beads of water on your car when you're done. Water does not interact very well with air. It likes to stick to itself and stay away from air, so it forms beads. Now, since the lining of your lungs is water-based, that lining is going to want to stick to itself and form beads, which would cause collapse of alveoli. When alveoli collapse, you can't breathe very well. That would be a restrictive lung disease. And so we prevent that from happening because type 2 alveolar cells, type 1 alveolar cells, are the actual simple squamous alveoli cells themselves. Right? Simple squamous epithelium, flat epithelial cells, type 1. Type 2 cells make and release surfactant. Surfactant is a detergent molecule. It has the same chemical structure as detergents that you will find in laundry detergent, dish soap, etc. And the purpose is to reduce the attractive forces between water molecules, to reduce the collapsing force. Babies who are born prematurely, less than 26 to 28 weeks of gestation, Their type 2 alveolar cells haven't started making surfactant yet, or making enough to overcome this collapsing force, so they have to be put on a ventilator because their lungs will readily collapse. And then, of course, after their type 2 alveolar cells have started producing this surfactant, they can go back to breathing normally. Now, this collapse is governed by another physical law called Laplace's law. And Laplace's law basically says that the pressure that you need to prevent collapse of a cylinder or sphere is equivalent to 2 times the tension on the wall of the sphere or the cylinder over the radius. Now, you generally don't have any control over the tension. That would be a pathophysiological process, reduction or increase in wall tension. But you do have control over the radius. So what this basically says is that as the radius increases, the amount of force that you need to keep that alveolus inflated, or that tubule inflated, decreases. So larger structures, larger cylinders, larger spheres, larger alveoli are less likely to collapse than smaller alveoli. So in this example, we have 2 alveoli, different radii. Right? The pressure needed to maintain the alveolus and prevent it from collapsing is less in the alveolus that has the larger radius. So twice the radius, less the collapsing force. And of course, pulmonary surfactant, if you have these water molecules here, they're more attractive to each other in a smaller alveolus than they are in a larger alveolus. The surfactant prevents molecular interactions, which would favor collapse. It decreases that fluid cohesive force. So there's going to be less fluid cohesion the larger the alveolus radius is. And essentially how this relates to lung function is that if the collapsing force is great enough, if you've got less surfactant, or if the alveoli become small enough, or if mucus accumulates in the alveolus would collapse, and then it would push any air that's in it into neighboring alveoli. And this may not seem like a problem, except it reduces the amount of respiratory surface area. Most people, assuming an average size, shape, body type, have about as much surface area for gas exchange, have about as much respiratory membrane as would be the volume or the area of a tennis court, your regulation tennis court. Alveolar collapse is going to reduce that surface area. which is going to reduce the amount of area available for gas exchange. So it's going to affect CO2 diffusion out of the blood and O2 diffusion into the blood. And the problem here with alveolar collapse relates to friction. If you remember from physics, there are two types of friction. There is static friction and kinetic friction. Right? So static friction, so when you park a car on a hill, the static friction between the tires and the asphalt or whatever concrete prevents the car had to silence that ringer, sorry, prevents the car from rolling down the hill. I mean, assuming you have your parking brake on and all this other stuff. But if you park on an icy hill, the coefficient of static friction is so low that your car could possibly slide down the hill. Kinetic friction deals with the amount of friction with something that's moving. If you've ever moved furniture or anything else, you realize that it takes more force to get something to move, to start moving, so breaking that coefficient of static friction, than it does to keep it moving once you've got it moving, the kinetic friction coefficient. So the kinetic coefficient friction, or the kinetic friction, is basically between your tires and the road surface while you're driving. So if you go around a curve, right, the kinetic friction force is different for a dry road versus a wet road versus an icy frozen road. So what we're dealing with here is an alveoli that has already collapsed. Let's say this has collapsed. The amount of energy or the amount of work that it's going to take to re-inflate that alveolus is going to be far greater than what it would be to increase its volume were it partially inflated. So again, the difference between static friction, which requires a greater amount of effort or work, and kinetic friction, which requires less. So an abnormal condition of air in the pleural cavity would be known as what? Well, pleurisy is inflammation of, there should be two M's, the lining of the chest cavity. So it wouldn't be that. Lung cancer? Nah. Pneumothorax? Yes. Air in the lungs, or air in the pleural cavity, air in the thorax. Pulmonary edema would be swelling in the pulmonary circulation. Congestive failure would be too much fluid in the thorax so that the heart could no longer contract normally. Respiratory system, so we said getting to the spirograms, tidal volume, normal tidal volume, inhale, exhale, inhale, pen goes up, exhale, pen goes down. Normal tidal volume, let's say 500 milliliters of air. Every time you breathe normally at rest, about 500 milliliters of air go into and out of your lungs. If you decide to take a deep breath to the maximum, that would be your inspiratory reserve volume. if you decide after a normal tidal volume to exhale as much as you possibly could, that would be your expiratory reserve volume. Now, the sum total of those three volumes gives you what's called vital capacity, which is not to be confused with total lung capacity. Because your lungs never completely deflate, you always have a reserve volume left over. You always have some air in the lungs to keep them inflated. Now, your total inspiratory capacity is your tidal volume plus your inspiratory reserve volume. Your total functional residual capacity is your reserve volume plus your expiratory reserve volume. Those added together give you your total lung capacity, which should be around 6 liters. Something like that. Depends upon your size. Bigger people will have a bigger lung capacity. Smaller people have a smaller lung capacity. So if we do a spirographic representation here, we have a total lung capacity of 100%, which is approximately 6 liters, let's say. Vital capacity, that is how much you can inhale and exhale totally and still keep the lungs inflated with this reserve volume. And that should be about 80% of total lung capacity. So if I'm saying that total lung capacity is 6 liters, 80% of 6 liters is like, 5 point something. Along with a residual volume. Now, tidal volume, usually about 10% of total lung capacity. So if we're saying 6 liters here, we'd say 600 milliliters here, right? So if we drop this down to 5, we would say this was 500, and then this would be 4. Right? Yeah, that's probably 4.8. So why is that relevant? Well, it's relevant because it tells you about lung function. There are two things we know that give us a good idea about lung function from spirometry. One is the functional vital capacity. So how much can you completely fill your lungs with and then exhale? And here we're looking at a functional vital capacity of about 5.6 liters, something like that. And then the second thing we have to look at is, well, so that tells you about the lung tissue itself. Its elasticity and compliance. But what about the tubes? What about the bronchi, the bronchioles, the smaller alveolar tubes? How can we measure or look at what the state of those tubes happens to be? Well, then we do what's called an FEV1, forced expiratory volume, in 1 second. So how much air can you blow out of your lungs in 1 second? If your tubes are fine, if you don't have any blockages, don't have any problems with your elasticity as far as your lung tissue is concerned, your FEV1 should be about 80% of your forced vital capacity. Right? Within 1 second, you should be able to evacuate about 80% of your lung capacity. So under normal conditions, here we have an FEV1 of 3.3 and a vital capacity of 4.0. So that gives you an FEV1 to FVC ratio of 83%. Normal. If you have an obstructive disorder, so an obstructive disorder is obstructing flow, then what you're going to have is a greatly reduced FEV1. Right? You can't move air into and out of the lungs because there's some obstruction. The tubes are constricted. There's a blockage, something, excess mucus production. So the FEV1 is lower. But you would also expect a lower forced vital capacity. Right? Again, over time. Look at this time course here. 2 seconds. 4 seconds. Eventually, if you let them continue, they might be able to get down there. So an obstructive disorder really causes your FEV1 to FVC ratio to be extremely low, right? Much less than 80%. A restrictive disorder, so a disorder that restricts your ability to evacuate the lungs from air. So you've got fibrosis, you've got some type of increase in elasticity, decrease in compliance, something like that. You may see a relatively normal FEV1 to FVC ratio, but when you look at the actual values, you'll have a lower than normal FEV1 and a lower than normal FVC. Pathophysiologically speaking, so we look at diseases, things like emphysema. You're going to have excessive lung volumes. Emphysema is usually a loss of elasticity. Right? The lung tissue expands very readily. An increase in compliance. But it does not return to its normal shape or size. And that's an issue because you can't evacuate air normally. That's caused by a breakdown in lung tissue, usually damage from smoking over decades. Fibrosis is completely different. Fibrosis is an increase in elasticity and a decrease in compliance. In fibrosis, you simply can't inflate the lungs. That happens in cases of asbestos exposure, asbestosis, pulmonary fibrosis, things where you get pulmonary disease and an increase in lung healing causes fibrosis. Right, so in that case, your lung volume is going to dramatically decrease. So two separate disorders. Well, the other thing to consider is dead space. And dead space comes in two forms. There's anatomical dead space, things that you have no control over, and that's just the fact that the trachea and the bronchi and some of the bronchioles aren't thin enough to allow gas exchange. Period. The end. Not going to change that. Now, the other thing is physiologic dead space. Physiologic dead space is so alveoli that have become non-functional, blood flow that has decreased in order such that you can't maximize gas exchange between the air and the blood. You can estimate physiologic dead space via what's called the Bohr equation. The Bohr equation basically just takes into account, you can measure the amount of CO2 in an artery, so the arterial CO2. You can measure the amount of expired CO2, right? So the amount that is expelled when you exhale. Put that over the arterial CO2, which is your 100% mark. And what you get is an estimate of dead space. Right, so it's an estimate of how much lung volume does not participate in gas exchange. Physiologic dead space. Talk a little bit about ventilation rate. Ventilation rate is going to relate to gas exchange. So we've got two types of ventilation rates. We've got a pulmonary ventilation rate and an alveolar ventilation rate. Pulmonary ventilation rate is how much air comes into and out of the lungs in a minute. I apologize, I spilled my cranberry juice. Alveolar ventilation rate, however, is a measure of how much air actually gets to the alveoli and can participate in gas exchange. So if we look at what would be considered a normal respiratory rate, normal respiratory rate is 8 to 18 breaths per minute. Right, so a normal respiratory rate is about 10 breaths per minute. Normal tidal volume somewhere around 600. So then the volume is going to be basically the rate times the tidal volume. 6 liters. If we hyperventilate, so 30 breaths per minute, just try it. Don't do it for too long because you'll pass out. When you breathe very rapidly, your tidal volume decreases. You have less time to fill the lungs. But you still have the same minute volume. Right? So that, you still got the same amount of air moving into and out of the lungs. That says nothing, because you have the conducting zone and the dead space to deal with. So we have to correct for that. So we have what's called alveolar ventilation rate, AVR. Right? So you take your tidal volume, you subtract from that the amount of dead space or the dead space volume, and then multiply that by the respiratory rate. So if we then take your tidal volume minus your dead space volume, right now, even though you have fewer breaths per minute, you have a higher alveolar ventilation rate than if you are hyperventilating. So alveolar ventilation rate takes into account how much air actually gets to the alveoli to participate in gas exchange. So here's a little question. What's the maximum volume of air that the lungs can hold when healthy? Now this is going to depend upon size. Under normal conditions, assuming you're like 5'8", 160, 170 pounds, you would expect about 5,700 milliliters. Now if you're 5 feet tall and you weigh 100 pounds, it's going to be more in this direction. If you're 7 feet tall and 300 pounds, like Shaquille O'Neal, it's going to be more in this direction.